Hello there and welcome back. This is the second video on the paranasal sinus diseases. In the first, we covered the normal sinuses, mucosal thickenings, and inflammatory sinusitis. Now we're going to turn to masses within the sinuses, and we'll move from the benign and incidental to the destructive and malignant, closing with the rule that tells you when to refer. Study the guide and have the chart handy as well. All right, so fungal sinusitis, also known as a fungus ball. Fungal growth within the sinus produces non-specific symptoms, pain, mass, erosion of the walls, and altered nerve function. And it's associated usually with immunocompromised status, more commonly going to be in the elderly. Its appearance resembles either sinusitis or a destructive lesion. And one helpful clue, the calcifications in fungal sinusitis are more commonly centered within the sinus. That's different than bacterial sinusitis, where the calcifications are more often around the outside of the sinus. The differential does include both benign and malignant neoplasms. Aspergillosis is just a certain type of fungal infection with invasive and non-invasive forms. The invasive form typically occurs in immunocompromised patients. In this case, we see an opacified right maxillary sinus with those internal centralized calcifications indicative of a fungus ball or fungal sinusitis, in this case, aspergillosis. Mucormycosis is another form of fungal sinusitis, also called zygomycosis, more common in an uncontrolled diabetic, and then secondarily the immunocompromised. This one is very destructive, if you notice by these images. Producing black necrotic tissue. There is a predisposition in the ketoacidotic diabetic related to elevated serum iron, which supports fungal growth. This is the one in the group to take seriously. As you can see here, it can be rapidly destructive. All right, after those scary ones, this one isn't quite as scary. An Antrolith, a deposition of salts, calcium phosphate, or carbonate and magnesium, usually around a nidus, such as a foreign body. More often what you're going to see is calcification around just stagnant mucus or cellular debris at a site of previous inflammation. It is asymptomatic unless it grows large enough to produce sinus symptoms. If it starts to obstruct the drainage, then that could be a problem. So radiographically, just a well-defined, smooth or irregular with variable degree of calcification. You can see this one in the posterior sinus, this one more in the anterior sinus. The differential might include a root fragment, so look for a history of extracted tooth with potential root. Then also a rhinolith, the calcification within the nasal cavity. So these are typically inconsequential. If they are symptomatic, then surgical removal may be necessary. When you're asked to name a calcific accumulation within the maxillary sinus, this is it. Whatever the source might be, you can refer to it as an Antrolith. So what's really common to see is small calcifications along the sinus floor just from some inspissated or some dried out mucus. So you see that with some frequency in 3D volumes, but these small incidental ones are so common that it's worth at least commenting on and saying there's some calcification in there, probably just some dystrophic calcification. Now on to osteoma. This is your callback from the toffee topic. Going to be twice as common in men, usually asymptomatic. Just like with Antroliths, usually not requiring any treatment unless it grows large enough to obstruct the sinus drainages or cause symptoms. In the sinuses, its distribution is characteristic about 80% of the frontal sinuses, so that's really common to see in the frontal sinuses. If you really start looking at CBCTs, you're going to start seeing these. 15% in the ethmoid air cells, 5% in the maxillary sinuses, and then it is pretty rare in the sphenoid sinuses. So recall the different density variants. There's compact or ivory osteomas, which resemble corticobone, while mature or spongy osteomas show internal trabeculation. So just like with the osteomas we've already talked about. All right, now mucocele. We're returning to that term I asked you not to misuse for pseudocysts. This is something very different. Also called an empyema or pyocele. This is an expanding destructive lesion arising from a blocked sinus ostium, and it's nothing like a pseudocyst. It produces cheek fullness, radiating pain, loosening of the posterior teeth, nasal obstruction, diplopia, or proptosis. 90% of these will occur in the ethmoid or frontal sinuses. On imaging, it's just a filled, opacified sinus, and it starts to assume a round hydraulic shape. It's like the sinus itself becomes a benign tumor. It starts to expand, and as it does, it replaces and resorbs things. It can displace or resorb teeth. It may expand into the orbit or the sella. Fortunately, the most common pattern of expansion is going to be more medially and into the nasal cavity, and then you'll start seeing it destroy nasal structures, like the border of the nasal cavity. It'll even start to destroy the nasal turbinates. But of course, if it does expand into the orbit or the sella, that can cause problems for the patient. Radiating pain comes from pressure on the supraalveolar nerves. The distinction from a pseudocyst is the whole point. One is a harmless dome, and the other expands and destroys. This shows the beginning of a mucocele and is starting to destroy the floor of the orbit. You see the other side intact and normal. And so when you see one of these, you see expansion of the sinus borders. Here, as I said, you'll see it expand medially and start to destroy nasal structures. It's expanding laterally as well, buccally. So it may be very difficult to distinguish from a cyst or neoplasm. So look for evidence that's associated with an occluded ostium. And so this can happen in a patient with a history of sinusitis, although not always. So a papilloma is a rare neoplasm of respiratory epithelium. It's going to be more common in male. Typically these present with nasal obstruction, discharge, pain, or epistaxis. Arises in the ethmoid or the maxillary sinuses. Its radiographic appearance is non-specific. It's just a homogeneous soft tissue density, but it can erode through bone through pressure. It resembles a polyp, but the distinction matters. A papilloma is an actual neoplasm, whereas a polyp is just chronically inflamed mucosa. And so this image shows how it looks like a polyp. It has that corrugated borders, but it is expanding from the maxillary sinus into the nasal cavity. That's kind of a common finding for papillomas. And if it starts destroying bone, then you think, okay, this is more of a destructive thing, more of a true tumor. And while we're on the topic of sinus relief, if anybody has had or seen a sinonasal surgery, those splints are kind of surprisingly deep. And as a genuine last resort that I do not endorse, maybe the vodka rinse. All right, squamous cell carcinoma, we've talked about this, so this is another callback from ill-defined radiolucencies arising from epithelium, in this case of the mucosal lining of the sinus. So the sobering statistic, its symptoms mimic sinusitis and are typically present for 5 months or more before diagnosis. The presentation depends on location, nasal obstruction, a bleeding from the nasal cavity, dental pain, altered sensation, loose teeth from the sinus floor, diplopia, and cheek paresthesia from the orbital floor. Trismus, a referred ear pain, could occur from the posterior wall. The mean age is around 60. It's twice as common in men, more common in the maxilla than frontal or sphenoid. So radiographically, it's destructive, soft tissue opacity. It destroys the bone around teeth. So look for signs of this. This is something you may catch as a dentist. Even though we kind of think of the sinuses outside of our realm, a lot of our imaging shows the sinuses pretty well, and that's why I teach my students always look for those sinus borders. Make sure those are intact. You could potentially catch a carcinoma arising from the sinus. In these next few cases, you'll notice a theme. Look for the sinus borders. On this side, they're mostly intact, maybe a little obscured here, but on the left side, they're completely destroyed, as well as my favorite structure. There's no zygomatic process. The alveolar bone is completely destroyed. So this is a bony destructive lesion. In this Waters view, you first may notice just the opacified sinus. Is it just sinusitis? But look for the sinus borders, which on the right side, completely intact, uniform, corticated. On the left side, they're destroyed. So indication of a destructive lesion. Of course, it's a lot easier, I think, when you have a 3D view, and you can really appreciate the bony destruction, not only the posterior lateral border, but the medial border as well. And then here we have the same image, just soft tissue window, so we can more fully appreciate the soft tissue extent of the tumor. And even though the soft tissue borders look well defined, it's not one of those well-defined corticated cyst lesions. If it's this destructive and expanding and just destroying cortical borders like this, think more malignancy. And so loss of that cortical integrity was a recurring theme that we saw there. Look for that. And your differential is going to include sinusitis. As we said, a lot of times these go undiagnosed because a patient has symptoms and they just chalk it up to sinusitis. So look for these subtle signs of bony destruction. A large retention pseudocyst, usually going to have more of a nice dome shaped, not continue to grow. Watch for that sinus destruction. Odontogenic cysts and infection could be confused with the carcinoma. And then here's the clinical pearl to carry. If you suspect a neoplasm in an older patient who develops chronic sinusitis for the first time without any cause, be wary of that. And now I want to do a brief note on sinonasal destruction. This does have a broad differential of its own. So a lot of times you see the nasal septum just completely obliterated. It's gone. And there are a lot of different causes of that. It could be previous trauma, prior surgery, or granulomatous disease. And well documented in the literature is cocaine abuse or other drug abuse. So the point for our purpose is destruction of the septum and sinonasal structure has causes beyond neoplasm, and that makes the history matter. Dig into the history of the patient. Maybe you can determine why they've had destruction, because I've seen this in several instances. We'll catch this on our CBCTs. So this is the key slide to remember from the entire lecture. Whenever you have an opacified sinus, look for bony destruction. If you see bony destruction, refer it immediately. Advanced imaging, MDCT, MRI, these demonstrate the soft tissue extent better than a CBCT. And MRI in particular can distinguish simple mucus accumulation from a true soft tissue neoplastic mass. Opacification alone is common and usually benign, but opacification with bony destruction is the finding that demands that you act. Now let's go over several cases, revisiting those principles. What do we see here in this periapical image? Notice kind of a granular appearance. Notice the raised cortical outline, but it's kind of a mixed granular appearance. Radiolucency around the outside. This is just an osseous dysplasia that's expanding into the sinus. Now the osseous dysplasia has caused kind of a loss of that corticated border, but this is still just suspected osseous dysplasia. And here we have another well-defined opacity outlined by a radiolucency expanding into the sinus. Kind of looks like an Antrolith, but this is, again, just a residual cemento-osseous dysplasia. The sinus is then pneumatized around it. Remember how I said the sinuses continue to grow or pneumatize as we age? And so it grows around things like this. Things that are dense, it'll kind of grow and pneumatize around. And so this is a residual cemento-osseous dysplasia as well. What do we see over here? Opacification of the left sinus, loss of the sinus borders. But look at the kind of granular, almost cotton wool in some cases appearance. But more so, I'd say most of it is granular and something expanding into the sinus. What does that look like to you? That's our fibrous dysplasia. So osseous dysplasia in proximity of the maxillary sinus can behave similar to a benign cyst. Largely, like in this case, it's because the sinus is pneumatizing around it, not because it's continuing to grow into it, although it may be a combination of both. And then that was our fibrous dysplasia, expanding bone, displacing sinus borders, relatively shrinking the sinus, right? Because it's growing into its place. All right, hopefully you're starting to appreciate the appearance. When you see this and it's just kind of a moderate gray value, we'll typically describe that as ground glass. So this ground glass appearance filling the sinus, it's a little more hyperdense than just soft tissue or fluid. And so there is more of a fibro-osseous thing filling the sinus. So again, just a classic fibrous dysplasia. Here's another one, that ground glass appearance. Hopefully right away you're suspecting fibrous dysplasia. I don't see any encapsulated tumor-like thing, so you might want to be ruling out ossifying fibroma. This is more your fibrous dysplasia, but why does it have such a defined border here? Remember I said in most cases of fibrous dysplasia, it's isolated to one bone. It's monostotic. And so if you have a suture line, in this case, the zygomatico-maxillary suture is right there, and so the fibrous dysplasia terminates abruptly. So there it does have a well-defined border. Then what's different about this one here? Is that fibrous dysplasia? Is it like these, just kind of growing from the bone into the sinus, or this more just the thickening sclerotic bone? Yeah, this looks like your typical sclerotic bone of chronic sinusitis. So a little comparison there. All right, here we have an edentulous patient, maybe a cropped panoramic view. What does this look like inside the maxillary sinus? It looks to me like a root tip. And contrast that with this one. What's the big difference here? Look at the PDL space. So this having an intact uniform PDL space tells you it is still within bone. It looks like the palatal root, so it's probably just on the palatal side of that sinus. As the sinus pneumatized around it, pneumatized around the buccal surface. Whereas this one, I don't see that nice PDL space. This may be an actual root that's embedded in the sinus or left within the sinus. On image C here, it looks like a root tip, but this may just be dystrophic calcification of inspissated mucus. Like I said, you'll see that frequently. This one I showed you in our anatomical lectures. It almost looks like a root here, but it's actually just an anatomical structure from the mandible. That's the coronoid process. All right, and this patient complained of a slow-growing indurated mass. He attributed it just to a food rubbing against that part of the mouth, the hard palate. But as we'll see with imaging, this proved to be something a lot more ominous. So here's the imaging of that patient. How would you describe this lesion? Is it well-defined and corticated? Is it ill-defined and ragged? What does that mean as far as category? That's more of a malignancy. Hopefully you can recognize that with the imaging, even though we described it as slow and maybe it felt like an indurated swelling. So here's one where imaging tells the whole story almost. That ill-defined maxillary radiolucency. So a reminder that a sinus malignancy can first denounce itself through the mouth. This was a carcinoma that arose in the sinus, then eroded through the alveolar bone and into the hard palate as we saw there. All right, this patient had a painful purplish swelling. Is that your typical inflammatory lesion? Not really when it's purple like this. And so you probably want to get some imaging, right? So here's our panoramic image. Notice the calcifications inside. What did I say about the location of calcifications? Is if it's internal, it's what? Is it bacterial or fungal? The bacterial, your typical sinusitis, if you get calcification, it occurs around the periphery, around the outside of the sinus. The fungal one that accumulates on the inside first. And so this looks like a fungal sinusitis. And this was Aspergillosis. This was a young woman after induction chemotherapy for leukemia. And so she was left immunocompromised, which made her more susceptible to this Aspergillosis. And pay attention to that, particularly in immunocompromised patients, those with leukemia, or perhaps on high-dose corticosteroids. And so to close, here's an actual radiograph of Kermit the Frog. look at his sinuses, they look surprisingly like hand bones. So that's interesting. So that completes the paranasal sinus diseases. The organizing principle holds throughout. Name every departure from black. Air should be black. That's normal in the sinus. Name it precisely because the name determines whether you ignore it, treat it, or refer it. And last point, never let an opacified sinus with destroyed borders go unreferred. All right, see you on the next one. Thanks.